Good evening, everyone. Today will be the third series of the third day of the series of social health insurance. With us today is Dr. Salim Hussein, together with Dr. Maureen Kimani from the Ministry of Health. Dr. Salim heads the Division of Primary Healthcare in the Ministry of Health, and he's been working for many years in the sector of primary health care, and to foster a lot in community health. Dr. Maureen Kimani has also been in the same space, and she's heading the Division of Community Health in the Ministry of Health. As I had explained earlier on 19th October, we had 4 laws that came into, that were enacted, 3 of which are the ones that we're discussing. We had the Social Health Insurance Act, which we discussed on Monday. Then yesterday we discussed the Digital Health Agency, which was brought about by the Digital Health Act. And today we will discuss basically we will talk about primary healthcare and primary healthcare networks, which is anchored by the law of primary healthcare. So Daktari, karibu Dr. Salim. Utaanza, then I think you can share your screen. Dr. Salim, did we lose you?
Not Daktari. I'm just having a problem with.
And we'll share the screen. Sorry. Sorry about that. Dr. Salim will join us shortly. Dr. Maureen, how are you? Karibu, Dr. Salim.
Thank you very much. Good evening, everyone. Apologies for the small technical hitch. I will proceed with the presentation on the primary healthcare and primary healthcare network. This is part of the series of the social health insurance that have been going on. As you all know, there were 4 acts that were ascended, including the Primary Healthcare Act. Next slide. Just as a background of the country, we have some parameters that we look at when we are planning and also when we are giving health services. More importantly for us, the population. Most of our primary health care networks, especially the community health units, are based on population. And later, my colleague will be presenting on community health services. You'll see that our community health units take care of a population of 5,000, which constitute the community health unit. We have a gross domestic product per capita. This means that the nation, when it is healthy, it produces economically. This is the amount that we are looking at more developed countries. This is usually higher. Our life expectancy at birth is 66. We country where they're doing better in terms of health services. This is above 80%. Our total expenditure is about 5.6. We know that we are aiming to get it to 15%, which is the Abuja declaration. This means that we'll have more resources for our different building blocks, including human resource, commodities, service delivery, and financing. Our maternal mortality rate is at 355 per 100,000 life birth, which is one of the indicators, health indicators that show that there is a good or quality health services in a country, including the neonatal or the child health parameters like the under 5, which is about 41. So for countries that they're doing well, the maternal mortality is below 10%, and the under 5 is also below 10%. Next. So just for all of us to be on the same page, I would like us briefly, one of the definition of primary health care is that this is essential health care that is made universally accessible to individuals in a manner that is acceptable to them, takes care of their custom, cultures, beliefs, and through their full participation. So they should engage. When we are going to look at the PCN, we'll see that we are looking at the urgent priority needs of the community in their areas, and in a manner that they can afford and the country can afford. So when you look at this principle, basically, they are most of the principle under UHC. PHC has been shown as one of the most efficient and cost-effective way to organize a health system. Here in Kenya, we actually here in Kenya, we actually did case investment, and it was shown that when we implement our primary health care the way it is expected, is 1 to 16. Next slide, please. So why justification, why invest in PHC? Beside the cost effectiveness, it has been shown as one of the way to give high quality, low cost care. It is more equitable, especially when it is looking at different areas and the different needs of the people. It serves as an early warning system because the lower levels, the community are empowered. There is a workforce there that looks at any potential problems or epidemics so that we can deal with the same. It empowers the individuals because one of the principles of primary health care is empowering individuals, families, and communities so that they can take control of and over their health. And this also has been shown that is one of the way it increases access to more appropriate services which are integrated, comprehensive, and closer to the people. And this is one of the way that we're implementing our CAFE so that we are looking at the different cohorts from birth to the elderly. Next slide, please. So we all know that the government agenda, the bottom-up economic transformation agenda, PITA 2022-2027, has some of the social determinants that it's looking at, and we are glad that healthcare, especially the issue of getting health closer to the people, what we are calling afya mashinani, is actually very close to what PHC principles actually entail. Next slide. So besides the four pillars of UHC, the better healthcare looks also at high primary and community health impact intervention so that we can support all the other programs in a manner that we are reducing the burden of diseases. We are empowering the people to have more promotive services and have positive behavior changes. The others include, of course, the human resources, very important, as one of the building blocks. Having effective supply chain of health products, technology, and commodity for security, financing for PHC, especially now looking at the PHC fund in the SHA that will be giving sustainable financing to PHC, which is one of the approach we are using to get to UHC. Of course, digital superhighway, which is very important for us to have our digital health platform and other smart innovation that we'll have, including the smart PCN and the ECHIS, which is currently being used and it has been seen to be very resourceful. Next. So basically, we are trying to move from some of the state that we are currently, the system that is very curative, to a more preventative and promotive approach, where the services were not integrated, there was verticalization, there was silo, to a more integrated, comprehensive services provision, where we had different levels not talking to each other. We had a lot of fragmentation to have levels, especially level 4, 3, 2, and 1, that they can talk to each other, they can be better coordinated, they can be more effective and efficient. That is actually what we call the PCN. And then we want to move away from where PHC was looked at secondary and it was not given finance, to where we're having sustainable financing in primary healthcare space. Next. Next slide. So it has been a journey for us since 1978, when we had the Alma Ata, which was looking at people adopting PHC, moving from theory to more of a practical implementation intervention in health space. We have had other meetings in Astana, that is 2018 and 2023, where they were looking at reloading PHC. And more importantly for us, during the National Health Sector Strategic Plan, 2, where we looked at the investment that we are doing, but our health indicators were not improving. So we came up actually in 2006, the community health strategy and the implementation of CARE. So it has been an improvement all the way. 2018 was a lot of documentation policy documents that we launched. And in the space of community health, we had the digitalization landscape that we did, and most of the documents were done. And currently, we are focusing on implementation, and we are glad that both governments that have been in place are looking at the PHC as an important aspect and approach to get to UHC. And severally, we have had regionally other countries coming to Kenya, including Ethiopia, Namibia, Malawi, and also had other global recognition. And currently, next week, we'll actually be hosting a team from UK to come and see what we are doing in PHC. Next slide. So I did mention that there were acts that were actually ascended by the president, that is including the Social Health Insurance Act, the Digital Health Act, the Facility Improvement Financing Act, and the Health Act, which had been done in 2017. And these will all be supporting the Primary Health Care Act, which are looking at giving a legal mandate and a framework for implementation of primary health services in the spectrum, including health promotion, prevention, curative, rehabilitative, palliative, across all levels and all programs, so that we can get to UHC. Next. So the objects or the main aim of this Act 1 is to fulfill the rights of people. That is towards giving them progressive realization of their rights. We know we are aiming to give the highest attainable standards of healthcare within our means. To have a systematic approach of implementation and giving different stakeholders different roles, to have appropriate mechanism and a mandate for the establishment of the primary healthcare networks, the community health units, and have a more centered engagement with the stakeholders for sustainable provision of primary healthcare services. Then the role of the multidisciplinary team, which we'll be looking at, is a technical arm that provides services in the primary healthcare networks, especially supporting the spokes. And then the provision of the role of the community health officers, the community health assistant, and the community health promoters, who are the community health workforce in the community health unit, to provide primary healthcare services. Next. So we have several policy directions that we will follow, and we are given direction, including WHO documents on primary health care, on the community health. Next. Nationally, we have documents that are giving us direction for the implementation of primary health care, including the Constitution, which gives this mandate of the promotion of primary health services to the counties. The Kenya Health Act 2017 clearly outlines that community health services is the foundation, it's the level 1 health services. Different documents, including the Kenya Health Policy, emphasizes on the use of PHC to get to UHC. Next. So we have a human resource for health norms and standards that gives the current standards for the human resource at the community health level, including the number of community health promoters and the number of community health assistants or officers. They have a scheme of service where the different cadres, including the community health officer, community health assistant, assistant community health officer are included. We know we are in a transition that the resources are dwindling from partners. So we need actually to be now looking at how, as a government, we move into putting more resources as the partners' funds are dwindling. Next. Down closer at the PHC fraternity, we have several documents that will follow. We have our Kenya Primary Health Care Strategic framework that gives the direction on implementation of PHC. Then when we're implementing our primary health care networks, we use the primary health care network guidelines. This is the document that we use to sensitize and orient our colleagues in the sub-counties to form the PCN. We have a document addressing social determinants of health. That is a framework for health in all policies approach, which is a WHO approach where we bring all non-health sectors to implement the areas which actually support a lot in the getting of health and well-being. Next. So what we call our primary health care network, we bring together level 4, that is the primary health care referral facility, usually the sub-county level 4 health facility, to work together to coordinate and to give support to the spokes, which include the dispensary, which are the level 2, the health centers level 3, and the community health units, which are the level 1. As I mentioned earlier, we use the primary health care network guidelines to implement our primary health care networks. Next. So in this primary healthcare network, we have different leadership, management, and governance structures, including the multidisciplinary team that I had mentioned. This is a team of different professionals working together to provide comprehensive and continuous person-centered primary healthcare services for individuals and families in communities, looking at the needs and the priorities of those communities. That's why they customize either the team or the services that they want to give so that they can address the issues, condition in that level. We have a primary healthcare network committee. Currently, more importantly, the shift is that we're including non-government entities like the private health providers, the faith-based health providers, several partners who support us in implementation of health. We include the community health committee member, which is the leadership, management, and governance body at the community health level, and a representative from the multidisciplinary team. Next. So for the function of the multidisciplinary team, mainly is to organize themselves, coordinate themselves so that they can give primary healthcare services to meet the needs of the community. These include overseeing the maintenance and management of the population data of the PCN, especially now we know that we have a lot of data coming from the EGs, our community health promoters who are collecting it, ensure all manner of referral, whether it's upward or downward, for patient services, support outreaches, especially moving to the spokes. These include the health center and the dispensary so that they reduce the workload of the clients coming to the higher levels, provide regular and periodic screening of some of the conditions in the community. Currently, we know community health promoters are screening for hypertension and diabetes. Hopefully, later we can move further to other conditions. Then strengthen the behavior change communication and communication development so that we can positively change the behavior of our communities, and then manage medical supplies in the PCN or in the community. We know this is very important as we are creating demand that our clients can actually get the commodities that they need. Next. So the other function of the same is to have a continuity of care within the PCN. This including health education, drug adherence, healthy eating habits, other lifestyle changes that are positive. home care, especially the issue of home-based care. We know our primary health care approach actually supported us in the mitigation and control of COVID. Most of our COVID clients actually recovered under the home-based care. And we know Kenya is one of the countries actually had low mortality and morbidity in COVID, especially for us using our primary health care network. Then have nutrition and assessment and counseling wherever possible at the different level. Coordinate the public health activities within the PCN. Other functions of the MDT include networking, share, service delivery, including resources. For example, the lab radiological services, support referral services within the PCN, supervise, train mental health workers in the spokes and the community health units, then monitor and evaluate the services, and more importantly, institute a fully equipped knowledge resource center at level 1 for community education, for exchange learning, and for improvement in best practices. Next. So when we go to sensitize our colleagues to form the PCNs at the sub-county level, this is the scope, which includes PHC as a global agenda. What I'd mentioned, that PHC currently is a government plan, that is the better transformative agenda 2022-2027. Then UHC, how do we support implementation of our national UHC policy? We look at different mechanisms of financing, but more importantly, reducing the out-of-pocket so that our clients are not disadvantaged. Then we give different national updates on PHC, including the documents that we have. The issue of costing, which we also did a strategic costing. We did a costing of the PCN operationalization. Then using the PCN guidelines, we take them through the different steps, which we'll be mentioning later. We take them through some of our community health policy documents and guidelines, health promotion the documents. Then usually get to know what is the PHC implementation in that county so that you can know what we need to change and move as a baseline from there. We do an assessment using the, 3 tools so that you can have an idea of the health indicators there, of the different building blocks, what do they have and what are the gaps and what can be done for the same. Then our colleagues in ICT and the Ministry of Digitalization support us in digitalization of the PCN. Hopefully, once these are there, it will support in electronic medical records sharing, telemedicine, payment and reimbursement. And then we look at the vital signs profile, looking at the primary health care, what funds are given to the same, what services are being provided, and have a proper monitoring, evaluation, and accountability and learning mechanism so that we can know, evaluate what we are doing, and also have a mechanism to share and learn amongst each other. Next. So when we're establishing a PCN, we have about 11 steps, including stakeholders sensitization, looking for governance, coordination, leadership, and management structures. We do the baseline that I had mentioned so that we can know the parameters already there. We want to know what the county actually implements at PHC. So we have a county presentation on PHC. We disseminate the baseline assessment that we do. Then we map the household, also the community health units to the hub, which are the level 4 facilities. Then we find different financing requirements. Currently, we are really focusing on the counties implementing the FIF, the Primary Health Care Fund, and the SHA once the reimbursement are given. Then we set a monitoring and evaluation system so that we can monitor the primary health care network's functionality and operationalization. And the last but not least, we usually targeting that all our PCNs will be digitalized, including the issue of each is operating together with a facility level digital system. Next. So the current status of our PCN establishment, out of the 315 expected primary healthcare networks, we have 191 that actually we have established and are being operationalized. We have about 10 which are currently ongoing, I think the process of being established. We have about 26 that started but have stalled because of one reason or the other. Then we have 88 PCNs that we have not started. Currently, out of the 47 counties, we have 43 counties that actually have established at least one PCN. So we just have about one county that has not established any, 2 counties that have not established any PCN. And we have about 16 counties already that have established all their needed PCNs in their counties. Next. So we are seeing that PCNs will be enablers of AHC because they are people-centered. They're bringing up integration. We're avoiding the silos, verticalization of programming. We hopefully that they'll be giving services in a timely manner, looking at equity and equitable distribution. We are looking that they'll be more safe, looking at the custom of the people, the needs closer to them. They'll be more efficient and effective, and more importantly, in the long run, they'll enable provision of quality health services. So PCN are enablers. They help integration at different levels, including the health levels. The different workforce are working together. The programs, they'll be able to be integrated and being done in a comprehensive manner. We'll bring different sectors so that we work together, so that we get health and well-being. The communities are being brought on board. They are meaningful, being engaged, and their priorities are being looked at. And we believe that our primary health care will be an enabler to get primary health for our people. Next. So some of the expected outcomes, we believe, and we already are seeing this as we are doing evaluation, reduce workload at the higher levels, especially when our community health promoters and multidisciplinary team are giving services closer to the people. They are also empowering them to have preventive and promotive intervention and services, and empower the communities to take control of their health. We're already seeing my colleague, Dr. Maureen, I'll be showing this, that we're already identifying people who previously did not know that they have a certain condition, for example, diabetes and hypertension in the clinics, and they have been referred for services. Several services are being integrated, so they're being given in a comprehensive manner. There is now a lot of advocacy for increased investment in the primary healthcare space. We believe that the primary healthcare networks will be better for referral, especially as people are registering to the SHA, because every individual will be allocated a PCN. So there will be a triage of a person to move before moving to the higher levels. We need to go to level 2 or level 3. And if there's any need to be referred either upwards or downwards, this PCN will be very important and crucial. There will be more patient-centered and not looking at the condition, but at the person in a holistic manner. We believe that with the digitalization, with the collection of the data, we'll have improved data utilization, analysis used at different levels, including policy, planning, and interventions. Next. So some of the achievements that we have had so far: we trained 248 primary healthcare master trainers, so that anytime we need to go to the counties or we are needed to support, we can have trainers. We have now 191 PCNs that already have been established. Some of the PCNs that were established have been gazetted and are functional. There is better referral system, which include the different levels in the PCN. There is more service coverage, especially the counties, the PCNs that are already starting outreaches and inreaches to the different spokes. There is better collaboration within the programs, including the wide stakeholders in non-health sectors, and also the partners supporting PSC implementation. And we believe this will enable introduction of workload in these certain areas where the disease prevention control has been done, but also other conditions have been managed at the lower levels. Next. So we are seeing more patient-centered. We have areas where the MDTs go as a team, and they look at the client as a person with a different condition, and they're treated at the same level. More reduction in silos. There is currently training of our CHPs is done as a package and not in different programs or technical areas. There's improved data utilization, especially what we're getting for planning. There is a lot of knowledge management, which supports different dissemination and support of on-the-job training at the facility levels, especially the community health promoters. There's continued progress and innovation, whereby we are seeing in different levels, for example, where the use of mobile labs or drones in Kisumu, as we'll be seeing, to support the PCN implementation. Then in different areas, we have seen, for example, in Garissa County, where already they implemented their own community health services bill, and they had passed the F5 bill to support PHC activities. We have seen the gazettement of the various of the PCN that we have established. We have seen, I mentioned this in Kisumu, drone use to support the distribution of commodities and the inclusion of faith-based and private sector into the PCN. Next. So in other areas like Kwale, they have a mobile obstetric ultrasound that the MDTs move to give those services in the household. Counties like Nairobi and Lamu, we have MDTs that are moving to the household, and we have had that they even given, for example, physiotherapy to people who are immobile until they became mobile. Garissa has increased their fully immunized coverage since they started the PCN. We have different infrastructure that have been improved because of establishing the PCN. We have more people profiling, including people to the household level. Reduce workload at different facilities, the integration of these MDTs of different services, including areas like Busia. Then we have more outreaches now that are planned, not ad hoc, that give services to the lower levels, including immunization, family planning, for example, in Garissa. And there is more increased advocacy for increased investment in primary healthcare facilities. Next. So when we are establishing a PCN, we have a functionality criteria, including some of the steps that we sensitize our colleagues in establishment of the PCN. That is the hub, that is the level 4 identification, where there are special conditions or needs. They can have a level 3 with a higher workload, or they can form what we call sub-hubs to take care, for example, area where they're very extensive or they have higher population. That we need to have a functional community health unit for that PCN to be termed functional. We have the household registration. We need to have a functional MDT. There is a lead, should be identified to lead the MDT. The gazettement of the PCN, of the respective PCNs. We have a PCN coordinator who is a sub-county MOH. Then have coordinated referral system, then organizing the MDT so that they can have a regular, for example, monthly outreaches, and then whenever possible, organization of a specialist or MO to visit the hubs to support and give them services. Next. So for the operationalization and sustainability of these PCNs, they need to be programmed as a program so that there's integration and comprehensiveness, and it's looked as long-term, not as a project. The use, increase, and the proper use of the human resource is very important, especially where there are gaps. We know the MDTs in some areas, they actually go to the spoke and support either the single or the less fewer health workers in those spokes for them to give services. These planned outreaches, they enable provision of services at the lower level. In terms of accountability, economic accountability, in terms of procurement, there is need of sharing and health staffs, especially where the facility did not have this, because we know once we start using the FIF, the issues of quantification, there'll be issues of procurement and issues of finance management. So they might need to look at sharing and health staff. We are orienting the leadership management and the governance. We have the County Primary Healthcare Advisory Committee in the Primary Healthcare Act. We have the MDT's provision in the Act. We have the PCN Committee, which we had mentioned. Then they need to plan for preventive and promotive activities, including the screening that are going on currently. Next. So we believe for this to be sustainable and to be operationalized, PHC need to be given priority, and we are happy that it's a government, it's a Ministry of Health, it's a regional, it's also a global agenda, so that the PHC is planned as a program. They need to be in the AWPs, they need to be in the county integrated development plans. There's need to mainstream wherever possible of PHC into other program and other program PHC wherever it is possible to operationalize the various acts that have been ascended to, including the Social Health Insurance, Digital Health, Facility Improvement Financing Act, and the Primary Healthcare Fund. The making of the PCNs smart will really enable facilitation of provision of services. Then they need to put aside the funds from FIF so that they can actually support the implementation of PHC, and wherever other sources can be obtained, including government partners and philanthropists, to be put into PHC implementation. And then it's very vital that we have various innovation, which already we are seeing in terms of both technical and social, so that we can do things differently. Next. So we have a functionality criteria, which we had mentioned, so that when we say PCN is functional, so we look at these 9 aspects, which are already mentioned, so that we can say this is functional. So the next step that we go is operationalizing of this functional PCN. Next. So just as a guide, sometimes people just look at what is very cost intensive or resource intensive, but we believe that operationalizing of a PCN, we can start from a person, you as an individual. What are these things that you can do to yourself, including self-care? Then after that, what you can advise, what you can inform, or what you can sensitize to your peers and the family. Then at your work station, what is it that you can do for your clients, but also what can you do for the staff, including screening, including talks, including health education. And then where mostly of us are focused, the outreach, which are the MDTs that are done. You need to give the services outside, but more importantly, also to work with other non-health sectors so that you can deal with social determinants of health. Next. So under self-care, there are several areas that we can look at, including physical, mental, emotional, and social, spiritual, environmental, and recreational self-care, so that we are not leaving ourselves behind, especially when you have a cover. It is also important to do an annual medical checkup. Next. So when we are dealing with social determinants of health, it is clearly indicated in the WHO conceptual framework, and we know this is very important. Several non-health sectors affect us, including roads, water, digitalization, electricity, and also nutrition. So it's very important that we have mechanism to work together with them. Next. So we have various challenges. I think funding is one of the major challenges in the area of PHC and PCN. Sometimes still the verticalization silo programming comes in. We have several gaps in the building blocks, including the HRH. The issue of organization of the MDTs, this is something that currently needs a lot of logistics planning, movement, funds to go to the lower level. Of course, there's no one fit solution to all. Sometimes we have seen that the community health promoters are creating demand, but the supply is not meeting the demand. We even had cases where now the facility actually referring to the CHPs for them to do random blood sugar and blood pressure checks, because some of those consumables are not in the facility. Then, of course, handling of the PCN, these for the payments for the entities, these needs a lot of planning. Then some of these outreaches are very cost intensive, but can ride on the other already programming like immunization and RAMCA. Of course, making the PCN smart, this is cost intensive, and there's a lot of data management to be done. Asanteni sana. Dr. Maureen will be taking us through a bit of the community health services in Kenya. Thank you very much. Back to you, Session Chair.
Thank you. Thank you very much, Dr. Salim, for the very comprehensive and very good work that you've been doing together with your team. Dr. Maureen, I hope your audio is sorted out.
Can you hear me?
Yes, I can hear you.
Okay. Will you project the presentation?
Yes. Kindly, Nelson, kindly project. So before Maureen starts, I have a small the memory of you. I remember one time I was taking some visitors around, and they were very interested in seeing community health promoters at work. Today we're discussing on primary healthcare networks, just to say I had firsthand seen how networks and how this thing works because Dr. Maureen called me and asked me, Daktari, today you're around there because I've been told there's somebody from the ministry. I was amazed at how uh, the working in collaboration, especially in an impromptu visit, could still be able to network all through. So, Daktari, karibu. We want to hear more from you.
Thanks, Sana Daktari. Good evening, everyone. I'm Dr. Maureen Kimani. I work at the Ministry of Health. I coordinate community health work at the ministry. Next slide. And now that Salim has really given an overall approach, remember community health is part of the PCN that the ministry is currently establishing. And we like to call it the foundation because we all come from communities, we all come from households, we all come from families. And we believe that health should start at that level and not at the facility level, because what people eat, how they do their sanitation, and how they're doing their household air pollution, all those things affect the health of individuals, and therefore it's critical that they take up the ownership for some of the things they're able to do so that we are able to prevent diseases, and we're also able to promote health right at the household level. And this is why as a ministry, and not just as ministry, and this is just a global agenda, we believe that starting at the foundation, at the household, at the individual level, would really help us in terms of improving our health outcomes. So basically, our overall goal is to ensure that we are promoting dignified livelihood throughout the country, and that we have the preventive promotive health services decentralized up to the household level, and that community members and Kenyans know that the actions I do, or the community health promoter who comes around to remind me of some of these actions, all this is contributing to my overall health. And we believe that by investing in this area, we're going to achieve much more in terms of looking at our health indicators, our mortality, life expectancy, and so forth, even in the near future. Next. So I think Salim has already touched on this, the policy support for community health, starting all the way from the Constitution to the Vision 2030, where community health is one of the government flagship projects from the MTP 3, and then the medium-term plan 3 that was done, and then the Kenya Health Act recognizing the community health as level 1 of the healthcare delivery in the country. Of course, in the Kenya Health Policy, where we want to ensure that everybody has the highest possible standard of health, and therefore, starting from their home, we can be able to do something, even as we progress to the higher levels of healthcare, and all the way to the many other documents that we have developed to support the policy and the legal framework for community health in the country. Next. So we also have evidence from various studies that have shown us that community health is effective, and there are different studies done around child health which show that by focusing some of the strategies at the household level that are towards disease prevention and health promotion, we can be able to have a more cost-effective health service implementation, and of course, in terms of maternal health, by ensuring that our community health promoters are able to educate based on the information we have trained them on their community members, so that they are able to access services for antenatal care, ensure that they have stillbirth delivery in the facility, and ensure that they understand some of the danger signs during pregnancy, so don't have, we avoid the high cost of dealing with complications. Then in terms of infectious disease, again, studies done in Ethiopia have shown that by utilizing the community health extension workers in Kenya, we have what you call the community health assistants. Then we're able to have to reduce the cost of supporting the infectious diseases such as TB. And then, of course, there are many studies around WASH. That is a low-cost interventions when we just train community on how to do hand washing. And I think for Kenya, we saw this during COVID, where hand washing was highly promoted. And actually, when you look at our HIS for that, during that time, we had a huge reduction in terms of some of these communicable diseases, such as diarrheal diseases that we normally see. And then, of course, issues around NCDs. We know that a lot of our NCDs are identified quite late, and therefore that increases the cost of care as well as mortality. And therefore, if we are able to support the communities or the individuals by giving them information at their level with someone who they know, who has been given some additional information, talk to them in a way that they can understand, then they are able to seek for these services much earlier. They don't delay to seek for help. So we also know that community health also accelerates other objectives beyond health. For example, in a UNICEF report, we've seen that for a child, if they don't attend school because they are always sick, then poor school performance means that in the future, they are likely to earn less, 20% less than if the child was healthy and was able to attend school. We also know that there's also possibility of increased employment. And these are some of the indirect benefits where if we have got all these issues that we have on board, majority, almost 70% of them are women. And even though it's just a stipend of 5,000 that they are getting from both the national and county government, still means a lot, because it's from 0 to 5,000. It still means a lot, especially in our rural poor population. Then, of course, the issues around women empowerment, where as I said, majority of them are women. With all the training that they are able to get, they are also able to improve on their care habits within their own home, and of course, spread it to their chairman, to their neighbors, and to other people, and therefore empowering. So the empowerment is one of the other objectives. And then, of course, issues around equality. And we also have this capacity and trust for the community to engage with our health system. And we have different tools that we have come up with, such as the community scorecard for social accountability of primary healthcare, where communities have a tool they can use to be able to give us feedback as a primary healthcare facility on some of the areas that we need to improve, so that we can see more uptake of the services that we provide. Okay. So for Kenya, as we know that we will achieve UHC through primary healthcare. So starting from the community level or at level 1. So we have looked at different pillars of the health system, and there's on these different pillars, there's been major investment in the last probably from 2018 coming forward, whether issues of community health financing have been dealt with, issues around the workforce, leadership and governance, community information system, where now we are moved away from use of the manual system to the use of the electronic community health information system, which is a tool that all the states are using to at least collect the basic health data from the households, and all that data. We are basically having a very huge data set of population population level health data. Then, of course, the issues around the kit, we know that that's another kit investment that the government has put in place. And we know because of all these things, there are several the outputs that we can already see, but ultimately, some of the outcomes that we expect to see is improve maternal and child health, decrease in communicable diseases, or even early identification of diseases, and therefore we are able to manage much better and reduce our healthcare costs in managing diseases. Then issues around outbreak prevention, so it can act as an early warning system by reporting any early events that happen in a village. Then the surveillance teams are able to respond to them very fast, and of course, we expect to improve quality of life for pregnant. So this is how the community health services are structured, and I think Dr. Salim already talked to this, where now we have the primary care network, where the community health units are some of the scope, and each community health unit is linked to a specific health facility. We provide oversight where the refer people, we provide support for commodities, where and also supervision support, mentorship support, data review, and all that that is happening, including engaging with the community during the dialogue days on some of the issues that have been seen at the facility, and probably the community needs to do something about it. Maybe there are increase in the real cases, what could be the cause, they identify the root causes, and they are able to together with the facility manage whatever it is to prevent future occurrences. Next. So currently, this is our coverage of the community health services. As you can see, in most of the counties, 70%, we have over 90% coverage of this community health unit. Remember, one community health unit has 10 community health promoters and a population of 5,000, about 1,000 households, and each promoter is expected to take care of 100 households, and these need to be households in their neighborhood. So they cannot move from one village and go to take care of households in a different village. They need to be from the same village. They have lived in that village for more than 5 years. They understand the dynamics in that area. They understand the people. They understand the nuances, the cultural, the social nuances. And therefore, when you give them the information, they are able to support the health system in enhancing demand for services and also access for services. Next. So in terms of financing, as I said, currently we have seen quite some investment in this area. First, we have a return on investment report, which shows that for every $1 invested in community health, we have a return of $9. We also saw that from the financial year 2023-2024, we had 37 counties that already paid stipend to their PhDs. They may not have paid all the consistently every time, but this is from zero. So since 2006, many of the counties did not even pay anything, but from the last financial year, so a lot of the counties pay a stipend to PhDs. We also know that all counties are currently captured 50% in their current budget for the financial year. We also have the PhD Act in place, which would really help to support the level 2, and the level 2 can now support the community health units under them by ensuring that when they quantify for anything that is needed, then they will also quantify for the community health. Then, of course, we have the PhD fund, which of course we are hoping again will push more resources into the community health space or into the prevention agenda, as well as the SIS. We also have counties that have passed the community health act within the county health assembly. So we currently have 14 counties where this have already been passed. And we know that we are paying the CHP currently 5,000. So in 37 counties in the last financial year, in some of the months it was 5,000. So this is a matching fund. The ministry paying 50% and the county paying the other 50%. Next. So in terms of achievement, we go very fast on this. We already have 107,000 community health promoters across the country. As I've shown the coverage earlier, we have each of the CHPs having a smartphone and they are able to collect this data. These smartphones are provided by the Ministry of Health and distributed to all the 7 counties based on the numbers of CHPs that they have. The national government also in 2023-24 was able to pay stipends in 45 counties. And then, of course, I said earlier that by the end of the financial year last year, 7 counties were paid stipends. They may have paid 1 or 2 months, but at least they paid something for that financial year. Next. We also know that for us to ensure that the quality basic health services being provided at that level by our lay health workers, we need to have very clear occupational standards, which we have developed in liaison with the Ministry of Labour to ensure that their scope of work is very, very defined, and this is also well defined in the Primary Healthcare Act, so that we ensure that they don't go beyond their scope of work, and there are penalties and charges that can be raised against them if they went beyond their scope of work. So we have continuously trained, of course, different partners, the counties, and of course, national government. And so far, there are ongoing training to ensure that some of the newly recruited PhDs have been trained on the basic modules so that they're able to provide quality services at that level. Then, of course, we have the CHP kit, which has the basic equipment for household health screening. The Katali talked about the BP machines, the glucometers, and the strips that they have been given so that they are able to do some screening after, of course, with some assessment, maybe asking a question on issues, and then it guides them to say, now, we need a blood sugar for this client because they have answered yes to this symptom-related question. Then you are able to use the blood sugar, and then for the high, then they are immediately referred to the health facilities. Then the other thing the ministry has done is that for a long time, we were using paper-based tools by the PhDs for those who have been in the primary healthcare space. You know, we had different tools. We had the MOH 513, MOH 518, MOH 515. We had the chalkboard, the MOH 516. We had a referral booklet from community facilities, the MOH 100. We also had one just for community management, especially for under 5, the MOH 521. So those are like almost 7 booklets that are registered as community health volunteers then used to carry around in their villages. But now all that has been replaced with one integrated mobile application, which we call the Electronic Community Health Information System, whose rollout began in October last year. And as at now, we have all 7 counties who having trained their PhDs on how to use the mobile application or moving from the manual system to the digital system. We have all the 7 counties on each, and we shall be doing this in the next slide. Next. So this just shows, so at national level, all this data comes to the MOH data center, and it's also stored at the Konza, so that we always have a backup. Nothing can happen to the all population level data that we have. So all the 7 counties are onboarded. And as I said, PHP has 100 households. Once they are mapped, there are 100 households, Then they have to go and collect basic health information about that household, the biodata of the household members, what is the environmental situation, do they have sanitation facilities, what is the source of water, how is just the basic things that you can collect that may affect health for that household. And so far, the CHPs have been able to record data on the issues for 7.6 million households. And in Kenya, based on the census of 2019, we have about 12.5 million households. So as you can see, we are not 100% covered in terms of community health promoters, especially in our urban areas, in the estates, in the apartments, in the high-end townhouses, and so forth. So you can see that we have done quite well because 7.6 is a good number. If we just take an average of about 10 million households who we need to register, at least we are almost at 3/4 away, even as we start to figure out the model that can work in the apartments, in the estates, in the urban areas, which currently may not be covered by community. So once they register the household, of course, they now go back to the household. We expect that at least every household will visit once in 3 months. Remember, PhDs are not full-time. They still are PhDs, but they are volunteering. They're still doing their mama mboga business. They're still a teacher or the chief or whatever other work that they do. But they give us 2 hours of their day. So in a week, we expect them to give us 10 hours to at least be able to do some of the work that they need to do in the household based on their training. Next. So in terms of screening, from October last year until August, the CHPs were able to screen 5.19 million Kenyans, and of these, 101,000 were referred to the health facility. So this is both by the symptom screening. There are 2 questions that are within each that they ask, and if those questions are positive, then we move on to a random blood sugar. And so, and refer those who are found to have high sugars to the health facility. And for hypertension, 3.8 million Kenyans have been screened, and 200,000 with high blood pressure. So in terms of maternal health, they also very keen on any household with an under 5 or a pregnant woman, and they have been able to identify 203,000 pregnant women, and those who are not yet attending the clinic, 84,000 have been referred for ANC. Then for the under 5, the main areas of concern they assess what the area disease, so they ask specific questions, they ask around the area, they have a more state, so they're able to take the media conference and identify the features of the under 5 and that refer appropriately. And of course, they have questions around malaria. They also look at heart breathing and refer all the children. So they have been able to screen for access for 27 million children from October till now. And this is data that we have in our system, which counties are able to access and of course make more meaningful information about it and use that information for planning, for allocating, for managing the community outreaches. So this is very critical information that the recipients will be writing on to enhance the work of the recipients management committee, so that they are really responding to the needs of the community rather than just doing some guesswork. So this is the provide that population health data we have lacked for a long time. Yeah. So of course we still have challenges. So we have the supervision of the CHPs. Remember we say CHPs are lay workers working only for 2 hours a day. So there needs to be someone who is ensuring that they're doing whatever it is they're supposed to do, that they are ensuring they visit all the households that have been marked to them, that they are providing whatever service they need to provide, that they are referring the patient to the health facility so that we don't come in place for management of the different health conditions. Then, of course, we have very limited number, only about 40% of our community health units are manned, because each unit should have one community health assistant. So what a lot of counties do is that one CHA is allocated maybe 2, 4, 5, even up to 10 community health units. So that becomes a challenge in terms of providing that support that they need. Then, of course, in some counties, they have to cover very long distances to move from one home to another, especially in the vast counties of the country. Then sometimes we have disparities in the training, and that's why we were really focusing on this. And of course, it affects the quality of the service that they're supposed to provide. Then we have the inadequate budget allocation, that approach to national and county level for prevention and health promotion. But now with the legal reforms that have been done, we hope to see a change in this and maybe it will no longer be a challenge. Then, of course, we have a few counties lagging behind. We have applied them with the key response. We have even we have rolled out the chief, but then there's some counties probably can see the household registration is not the optimal, and there are many reasons for this. But that's a challenge for us. And then, of course, we have suboptimal capacity at the community level to manage some of the that we have given them. Next. So we have different opportunities. So some of the opportunities is we have the PSC Act regulation. So we really want to leverage on this to enhance the work of the PSC, starting from the level 1. Then, of course, ensure that all counties are implementing the standard community health promoters, be very clear on what is their role, and that the healthcare workers in the link facilities are able to fully support, in addition to the multidisciplinary team, to support the work and provide more understanding to the community members through the platforms where PhDs are involved in the barazas. We have the community dialogue days where community members health issues. So to make those platforms more integrated, where health workers are also able to go to those community engagement platforms and really give some opportunities that we struggle to give everybody, because we can only use the facility, and that's the minority, not the entire population. Then ensure that we are providing a transport solution for PhD kids covering the bus areas, ensure that the training of the PhD for standardization and quality, and then achieve functionality in all counties to optimize, enhancing the system so that the system becomes more and more user-friendly and more better support our health system, and of course, we think about allocation. We have population that can help them do that. It is real time. They don't have to wait for a daily check. They don't have to wait for a census report to be able to do. Then, of course, ongoing performance monitoring and documentation of what is happening within the community health program, because we know that ultimately, with this in place, our PCS will be more vibrant and will be able to do much more than limited resources that are available in the that's the end of my presentation. Our slogan is Afya Nyumbani, and we hope that all our healthcare workers support the work of the ministry and the council of the
Thank you. Thank you very much, Dr. Maureen and Dr. Salim, for giving us overview of how the primary care network works and how community health workers feed into it. We have several questions, so I would start the first question to Dr. Salim. Can you kindly list out the responsibility of the hub and spokes and community health workers? Just, I know you've done it, but just repeat it for better understanding.
Thank you very much, Dr. Basically, for the hub, it will be giving capacity to the lower levels. That is level 3, that is the health centers, level 2, the dispensaries, and the level 1. Also, it will be mandated to provide services looking at the urgent needs, priorities, conditions that are occurring in that PCN. It need to support the lowers in terms of if they have gaps in human resource in commodities, they look at ways of doing it either with the outreaches, looking at beyond zero, or even moving some of the MDTs to some of those facilities. We know in some counties where the PCN members in the MDTs, they go to, for example, in a health center or dispensary and actually support in the workload there by either consulting or clerking the patient. More importantly, it will also be mandated in the issue of supporting the planning, whether the preventative, promotive health services, so that they can actually work as a team. They'll give different support even if they're not going to the lower levels. For example, if it is a psychiatrist or a nutritionist, they can have, for example, basic messages that they can package for the CHPs to be taking yearly or monthly. They can also decide that they give basic community diagnosis. For example, what mental diseases, mental condition could be simply things like if somebody used to do certain things, now they are not doing, that could be a potential problem. A child who never used to be irritated, not crying a lot of time, but now he has changed and is crying. It could pick that message for that month, for example, and give to the CHPs and do basic community diagnosis and help in referral. Then last but not least, the issue of early identification of condition, issues of potential problems or outbreaks in the community, so that they can support the other health workers who have been recruited by the government to try and mitigate and control the same and referral. Thank you. Back to Chair.
Thank you. Thank you very much. Thank you for the answer. I just want to look for Dr. Maureen. Simply put, how will the interaction between community health co-workers in with level 2, 3, 4, 5, 6 hospitals be like, in a simple manner?
So I didn't get the question. Elizabeth.
It's for Maureen.
Oh,
Okay.
thank you, Dr. Amina. So the PCN guidelines, and first we have the legal framework, which is very clear on how the different levels of the health care are linked to each other in terms of referral, both from community to the upper fertility and from fertility back to the community. So remember, most of our patients, especially patients of chronic care, will be at the community level, and it's important if they're coming from specific community health units, the health workers understand that thing, so that in case they need follow-up.
Sorry, Dr. You're not very audible.
Oh, I'm not right. And now?
Now you are. Yeah, better. Thank you.
Okay, let me then repeat. So I was just talking about there's a very clear legal framework right from the Health Act and even in the Primary Health Act on how the different systems of the different levels of the healthcare interact with each other, right from the level 1, that's the community, to the level 2, the level 3, up to the level 4, and then from the level 4, which is the primary hospital, to the secondary and the tertiary hospital. So there's a very clear interaction, but specifically at the primary healthcare level, each of the CHPs is linked, or each of the community health units is linked to link facility. It could be a level 2, a level 3, or sometimes a level 4, because that could be the nearest facility. And it's very clear that if they get a patient, they already tell them this is where you're supposed to go. But now, even with the PCN guidelines and the PHC Act now in place, they'll even be knowing which of the facilities within the PCN. Remember, we are not discriminating against the FBOs and the private facilities. So those should also be areas where patients can also be linked to based on how they have mapped and the scope and within the facilities, and how they have linked to the community health unit in that PCN. So that's very clear in the PCN guidelines, and the counties have a leeway to agree on which facilities will the community health promoters be able to refer people. And from there, from the scope, they already know they're supposed to refer. If they are not able to manage a case, then they refer to their hub, which is at the higher level, or there's an MDT, maybe a roving clinic, an MOPC, an SOPC that is held on maybe once a month, and they're able to mobilize the patient within the unit, within that scope, the level 2 or the level 3, so that they can come and see the patient as near as possible, based of course on some of the emerging issues. I hope I have responded. Chair.
Yes, Daktari. Yeah, yes, Daktari, you've given a comprehensive answer. And in the interest of time, I'll just ask one question from each one of you. Dr. Salim, in regards to the PCN, is there a budget that has been allocated to it, or is it partner driven? One of the audience is expressing concern that there's a lot of partner support dependency that might happen, and it might bring about an issue of sustainability. And also, there's something about, you mentioned about the PCN. Are they gazetted, and how many of them are gazetted, and do they even need to be gazetted? Thank you.
Thank you very much. Yeah, in terms of sustainability, I think we should look at two things. One, that PHC, we're not starting from zero. There's a lot of primary health care that have been going on, including the things I mentioned, like immunization, some aspect of reproductive health, and some aspect of the communicable diseases. But what we are doing with the PCN is bringing a method, standard way of doing things, so that we can increase the efficiency, the coordination, the communication, and talking of different levels, health workers, programs, and health sectors, so that we can do better. Most of the establishment that is coming up with the PCN has been done by partner support, but there is also government support from the national. There's some counties which actually they have done it themselves. But most of the operationalization, as you can see, putting them into the annual plan, in the county integrated development plan, is not a partner-driven thing. It has to be government, it has to be a county. The issue of gazettement is one of the functionality aspect that we are looking at, so that we can give it a legal mandate as it is in the act. So that's why it is one of the 9 functionality criteria for us to say that a PCN is functional. Then from there we move for it to just being from functional to be operationalized by giving the interventions and activity. Thank you. Back to you.
Thank you for that precise, concise answer. Back to you, Dr. Maureen, the last question. How is the yesterday we learned about whitelisting of the devices. I'm assuming the mobile phone has been whitelisted. How is the interoperability of each? Is it interoperable? Over to you, Doctor.
Thank you, Doc, for that. So the ICHIS app, the application itself is an application you can get on Google Play Store. But of course, when you go to the live site, you have to have credentials, unique credentials, so not everybody can just get in. Only a CHP registered in a certain county, in a certain account, in a certain community health unit can get the credentials. Then they are able to get on the system. So when they're on the system, doing their work as they move from one house to the other. The system works offline, so they are able to collect the data they need, everything. With the assessment, enter the data. At the point of submission, that's when they need to be online, and the system, the URL, which is the geo.k, is whitelisted so that the cases are able to submit the data seamlessly. Of course, there are challenges here and there. It's not be seamless, especially in the border counties, in counties where Safaricom connectivity is a challenge. So those are some of the things that the partnership between the ministry and Safaricom is working on resolving to make sure that the YTC service is actually working for all the 100,000 plus cases. Back to you, Chair.
Sorry. Yeah, thank you. Thank you very much for joining in. Just as a parting shot, in 1 minute, Salim, what would you want us to go as a take home message from today?
For me, is that for looking at the well-being of our clients in a holistic manner, so we become more patient-centered, and that we just work together as complementary. There's a lot that we can do together, unlike when we are moving vertically, and simple ailments like cholera actually are still a problem for us. So it means still we need to do a lot as a team, so that we can give services closer to our people. Thank you.
Thank you. Thank you very much. Dr. Maureen, what would your 1 minute take home message?
Thank you, Amina. For me, who is very much passionate about prevention, is that I think as health workers, we have a big role to play to support the communities in the areas where we are working, to make sure that prevention becomes a big agenda, the same way we are security services, but also prevention becomes one of the agendas that we really take seriously, and even support the community health promoters in all the ways we can, whether it's just supporting in terms of building their capacity, mentoring, and of course, when they have those community engagement platforms that can actually be present at MBT to answer some of the questions that they may not be able to answer because their knowledge, their training is very limited, and of course, some Kenyans have more information and we accurate. So I think that's one of the areas that we are really required to work together to ensure that the prevention agenda is amplified.
Okay, Dr. Lee. Sorry, I think there's a problem on my side. Perhaps on your side. However, thank you very much, Dr. Salim and Dr. Maureen, for tuning in and sparing your time to educate us and give us an overview picture of what the UHC agenda. Thank you for the role that you have played. It's not an easy and it's not it's a very impactful journey. For the audience, thank you very much for listening in. This audios will be uploaded on the Kenyatta YouTube channel. Thank you for joining in. The organizing team is preparing for another series, a continuation of the series next week, so that we can address some of the questions that we were unable to answer. You can reach out and ask questions so that the thing can be more guided. I hope this has been helpful. I hope this has clarified and opened up. It's a beginning. It's a beginning for us to be able to understand what the government is planning in terms of attaining UHC, the pillar of health financing through social health insurance, and digital and together with primary healthcare networks and community health workers. So thank you very much. Have a lovely night. Good night. Night, Dr. Ariz.
Good night. Thank you, Amina. Bye.